Just be mindful of everyone's time. Good evening again. On behalf of the Thoracic Surgery Medical Students Association, we are so happy to welcome you to our sixth annual CT Surgery Interest Day. My name is Nina Uzoigwe, and it's been an honor to serve as president of the TSMA, and we really thank you all for joining us this year. With that, I'll also share the floor with Kiana and Mark, who will also introduce themselves as well.
Hi everyone, my name is Kiana Zahiri. I'm a third-year med student at Brown in Providence, Rhode Island, and I'm the secretary of TSMA and very happy to be here with all of you tonight.
Nice to meet all of you. I'm Mark Bounzer. I'm the treasurer for the TSMA. I'm a second year medical student at Jefferson.
We're so glad to have you all here. And so tonight's program is really designed to give you a comprehensive look as to what it means to be in cardiothoracic surgery. And with that, we'll go into the next slide. It's so important that we start all of our sessions looking at the TSMA mission statement, and the TSMA is very much focused on being able to ignite early passion, deliver transformative education, and foster lifelong mentorship while building a community dedicated to really advancing the field for years to come. And so it's really important that we use this as our North Star in all of our programming, our workshops and events such as this. And we really look forward to being able to share the plethora of wisdom and knowledge that all of our attendings, our residents, and even people who are in this community and network that will talk about being able to be in this field as well. So looking forward to the event this evening. So today's agenda, we went through the welcome, we talked about our mission statement, and now we will go through our featured attending presentations. We'll also go through a series of different announcements of great things that are happening in the TSMA, things that we're really looking forward and been building very hard with our leadership council. And then we'll announce our special lottery winner. And then we'll have our CT surgery breakout in room basically session where you get to learn firsthand from different TSR residents about what it means to be a resident and also go through the procedure as you are building your skill set to become a fully fledged CT surgeon and attending. So with that, we will move forward to our first speaker. Happy to have Dr. Anarotakis give his first presentation talking about integrated versus traditional pathway. To those who are able to fill out the form, we have a question asking about where people are in terms of whether or not they want to go the integrated pathway or the traditional pathway. Mark, do you want to share some of those results with us real quick?
Yes. So we have 24 responses to which pathway do they choose. We have 58.3% saying dual apply, 29.2% integrated, and 12.5% traditional.
Interesting. That's a really interesting breakdown. With that, then, we'll let our attending take the floor and we can move forward to hearing his amazing presentation.
Well, thank you, Nina, and your colleagues for the kind invitation, and also to my colleagues on the call tonight for letting me go first as I have a conflict later. But it's really a privilege to be here speaking with all you this evening and just have a few slides. I'm not sure amazing slides, but a couple decades ago, there was just a single pathway, the traditional pathway. And if are you able to control my slides? Will you advance one? One more. And so just as an overview, and you all are, here mostly in the medical school research years, and some of our resident panelists, of course, in their training programs. But just to encapsulate what, the training means to become a cardiothoracic surgeon, well, there's the college and pre-medical curriculum, which presumably most all of you have completed, and then your medical school and or research years, which is 4 additional years after an undergraduate degree. Nowadays there's a strong emphasis on this gap year or additional, CV building, doing either extracurricular research, efforts to advance your leadership abilities. There's many different ways to craft, that gap year, but a lot of it revolves around academic pursuits in either a traditional lab or doing clinical research. And, that's sort of, this is from a JTCVS article encapsulated in CV building. And then, the meat of my next couple slides is about the residency training pathways, which the traditional pathway was 5 years of general surgery and then anywhere from 2 to 3 years of conventional cardiothoracic training. which I think all of us as faculty, completed. And then advanced training, whether it be congenital heart surgery, critical care fellowships, advanced aortic heart failure, specialized thoracic training, lung transplantation, or cardiothoracic transplant. There's many different sort of advanced training, additional years of experience that can be obtained, and then, different paths and considerations. So go forward one slide, please. And then just to summarize the duration, which is, a big part of the consideration in the pathways, although in the end, I don't think it's hugely different. But in the traditional pathway, it's typically 7 total years, 7 or 8, with 5 years of general surgery, and then either a 2 or a 3-year cardiothoracic residency or fellowship, with the ability to be board certified in both general surgery and cardiothoracic surgery. There are some hybrid or joint training programs, which are usually completed in the same institution, of like 4 years of general surgery plus 3 years of cardiothoracic, again, with the opportunity to achieve board certification in both general surgery as well as cardiothoracic. And then, of course, the newer paradigm, which has a lot of interest and enthusiasm, which has been in existence now well over a decade, probably nearing on 2 decades, with the I6 pathway, which encompasses 6 years of training, all of it specifically cardiothoracic, although there still is general surgery exposure, especially in the earlier years, with the ability to become board certified in cardiothoracic surgery. So if you advance to slide 1, please. So there's pros and cons to each, and I would say that lots of students that I've advised over the years, and probably my colleagues on the call with us this evening as well, there's pros and cons, and neither's perfect, but both are established, ways to become a cardiothoracic surgeon. And I think it's important, that you really consider and weigh these, but know that you can become an excellent cardiothoracic surgeon in either pathway. And so in the integrated pathway, some of the pros are an early focused exposure to cardiothoracic surgery, with certainly more operative experience in the junior years, although you still do have required exposures, in some of the general surgery experiences, trauma and acute care surgery, ICU experience, vascular surgery, et cetera. With a streamlined curriculum with dedicated CT mentorship and continuity. It is, I would say, a slightly faster path to independent CT practice, although it's really a year or so difference, and many integrated residents will go on to do advanced training, whether it be cardiothoracic transplantation or advanced aortic surgery, congenital heart surgery, advanced thoracic surgery, as I mentioned before. So maybe a year less in overall training, but it's not like it's cutting the training time in half, and that's because it takes an awful lot of time and energy to become, a skilled independent cardiothoracic surgeon. And so there's the curriculum that is set up in the integrated pathway does expose you to, cardiothoracic OR earlier than you would in a traditional pathway. There's integrated research and simulation opportunities that are tailored to the CT skill set, and certainly a strong identity and peer cohort centered on CT goals earlier in your training. Some additional pros are earlier exposure to some of the what I would call adjunctive skill sets like echo and cath lab that you don't really get it in a very structured way in traditional fellowships, at least historically, although there has been a shift to more of that exposure even in traditional programs as well, but you certainly get more of it in an integrated pathway. Some of the cons are an earlier commitment is required and somewhat limited flexibility to change specialties, although, there are always opportunities if you realize that, it's not the right fit for you. Less time for a broad general surgery foundation compared with the traditional track. It's a highly competitive selection process. There are many applicants for the number of spots, and a really highly competitive applicant pool, which I think speaks to the enthusiasm of late, towards folks in medical school wanting to become cardiothoracic surgeons. There are potential gaps if program rotations or faculty support, may wane at an institution. That's something to consider. And it is intense early specialization, and there's always risk of burnout in surgical training programs, and so that is a con, but that exists, no matter what, if you haven't found the right fit for your personality with the program. So if you advance to the next slide, I think this is my final slide. The traditional pathway, again, 5 years of general surgery. So you get, as a pro, a broad general surgery foundation which builds not just robust operative judgment, but also versatility. I call it grit that you really develop as a general surgery resident, and not that you can't achieve and learn those same principles as an integrated resident, but the progressive responsibility that you are exposed to, the moving on from junior resident and intern to senior resident to chief resident, and managing a team of younger residents below you, medical students, that really develops a lot of leadership skills and qualities that I think are very important as you become an independent attending surgeon. Again, not that those same qualities can't be refined in an integrated pathway, but I do think that that maturity is certainly something that, at least anecdotally, I've observed in folks who go through a traditional pathway. As well, if you're not yet decided as a medical student, it gives you the versatility to confirm your interest in CT surgery as a general surgery resident, rotating in the CT ICU, maybe even doing some research, partnering with the cardiothoracic surgeons at your institution, and also the flexibility to modify career plans. There's wider program availability, more training positions overall. There's also greater opportunity through the course of your general surgery residency to strengthen your CV with either dedicated academic time in the middle of your training, taking like a research sabbatical, which many general surgery programs afford that opportunity, or doing research, as you go, which is also available to many residents who are erstwhile and seek out those opportunities while in their general surgery training. And certainly mature trainees entering CT fellowship with autonomy and really, refined decision making and judgment, as well as the leadership qualities that I described. Some of the cons are it is a slightly longer total training time to, be out in independent CT practice. There's potentially the less focus on early CT exposure. There's certainly fewer CT cases during general surgery years, whereas decades ago, there were third-year general surgery residents that would get operative exposure, doing ASD repairs, and even, some proximal and distal anastomoses and coronary bypass as third-year residents. That is very uncommon nowadays in general surgery practice because of a litany of reasons, but that is certainly not the case as it was, in past decades. There can be transition stress as you apply for competitive CT fellowships in the middle of your general surgery training, particularly in the 4th year of your clinical general surgery training, which is one of typically the heavier operative exposure years where you may not want to be off, for interviews. Virtual interviews, I think, addresses that somewhat. There's variable fellowship quality, reliance on fellowship for CT, specific mentorship, and possible delayed networking within CT communities compared to your integrated peers who are starting those networking processes early on, immediately after medical school. Although, the STS and AATS as well, have opportunities for looking to the future scholarships, for example, both for medical students and general surgery residents, looking to the futures specific to the STS. But there are opportunities to, integrate yourself into the CT community, even as general surgery residents, although, that is a consideration. So I know that there's actually ample literature and studies that have been written about, the products of these variable training pathways, and it's something that is, quite discussed a lot. Distilling it down to 10 minutes or so this evening, I think greatly oversimplifies the relative merits of both the programs. But I just want to allay concerns that I know many successful cardiothoracic surgeons who completed integrated pathways, and of course, the traditional pathway is tried and true. And so, really, it's what most suits you and where you are in terms of your commitment to cardiothoracic surgery, as well as past research exposures. And so the key is just finding the program that is the right fit for you and your personality and your both short and long-term desires. So again, it's really been a privilege to be here this evening, and I'm just it's been such a joy to watch the TSMA grow, and Nina, you and all of your colleagues, I think, do a wonderful job with this organization, and really give you immense kudos for all the work that you all have done with this important endeavor. So thank you all.
Absolutely. Thank you so very much, Dr. Anatakis. We really appreciate your transparency and just being able to lay the pros and cons, especially for these pathways, and also the advisement that you've given on the TSMA advisory board these last few years. It's really valuable, the insights and the wisdom you're able to share, and we're so thankful to have your transparency and also your advice and wisdom throughout the time that TSMA has been active. With that, we've gotten a lot of different questions in the chat, both privately and also publicly, as we can see here. Because of time, I'll go through maybe one or two. So the question I see here, hello, thank you so much for organizing this amazing session. I was wondering if you could touch on if you feel that I6 programs are becoming the new de facto and that general surgery residencies are lowering the amount of CT exposure that they're providing.
So I don't think, I mean, this is, my opinion. I think there will always be, both pathways, and, there's, so I don't know that I6 will become the de facto, pathway. There will always be traditional training programs. There will always be a need. I think, because of the various pros that we described, there's a lot of enthusiasm, among students in medical school, and I think that's great. But traditional programs will always exist, in my opinion, and I think there's no move afoot to remove the traditional programs, and there will always be residents in general surgery who decide that they want to become cardiothoracic surgeons, and so I would just say I would not fear that opportunity will go away to you.
Hopefully it answers your question. Person who asked me the question privately. So next question that we see here, for applicants interested in academic CT surgery, how early should we define a research niche, and how important is having focused CT specific publications versus broader surgical research?
Well, I think that's a great question. And, as medical school curricula, move farther and farther away from grades, and now, USMLE step one being just pass fail, there's fewer metrics on which to, assess an applicant's abilities. And, the CV and the publications is one of those sort of objective metrics that we are able to look at. Having said that, we all know that there are many attributes that factor into a successful cardiothoracic surgeon beyond just, the ability to write and publish. And so it I would say is important, but it's not the only consideration. Certainly we see that the CVs of the applicants in integrated programs some of them can be quite extensive, but that's not an absolute prerequisite to match into an integrated program. Having said that, I do think it exposes you to the field. While relatively young in your medical training, I think it also gives you the exposure to confirm, your desires to become a cardiothoracic surgeon. So I think it is important, but it's not, it's not an absolute prerequisite.
Yeah, I would agree with that completely, but I would say for congenital, I think it is really important that you have spent some time sort of in the field, either doing research in the field or establishing some track record, just because of the nature of that specialty. So I think it probably is not a prerequisite for I-6 residencies, but it will certainly improve your chances of securing a congenital fellowship.
And improves your chances in an integrated pathway too. I mean, there's no doubt, all things being even, having, a robust CV is a differentiating factor. So I don't mean to discourage those research efforts by any means. It is important.
And I would agree with that. It does give us a metric on which to look at applicants, and also lets us know your true interest in the area.
Amazing. Thank you so much for sharing all your perspectives, especially if we think about specialties, subspecialty specific areas. With that, because of time, we'll move on to the next presentation from Dr. Maluski.
Could I share my screen and drive it?
absolutely.
Yeah, it'll be easier because I have a lot of animation on it. So let me just share my screen here. Sharing is not turned on. Can you turn that on?
Working on it now. Thank you, Kiana.
Okay. Oh boy. There we go. Just get back up here. So, I would just like to echo George's accolades of the Thoracic Surgery Medical Association. You have done an absolutely phenomenal job in the past several years, keeping medical students' interests, keeping the association going. You've done an excellent job, and I thank you very much for the opportunity to present. So the topic that I'd like to present right now is, when did you decide on CT surgery? Early versus mid versus late. And I actually asked to do this one because I think that it's very important to understand that the decision doesn't have to be made as you're transitioning from diapers to pull-ups. It can be made anywhere along your medical school journey or your residency journey. And I am basically the cautionary tale to let you know that. So when I was in high school, I decided I would like to be a cardiac surgeon. You have to remember that this was when there was just the Starr-Edwards valve, and this was back in 1970. So I decided I wanted to be a cardiac surgeon. Yes, no. There was no one to, encourage me to do this. I was very much discouraged to do so. And one of the reasons is when I was in high school, basically there were three opportunities for women in college, or for women. You could go to college and become a teacher, you could become a secretary, or you could get married and become a mother. All wonderful professions, but none of them included cardiac surgery. So I did go to college. I became a pharmacist. So I went to pharmacy school first, and then started to become a reality that I could actually do this. And when talking about, when was your decision? When did you decide to actually do this? I can remember it like it was yesterday. I was in biology lab. We had some animals there, and one animal was sick and had a cardiac arrest. My professor, who happened to also be a cardiac surgeon, did cardiac massage, opened the chest, did internal massage, and the animal lived and survived. I can remember that very second. That was when I decided I was going to be a cardiac surgeon. And it's not usual that you remember that actual time point. So I went to medical school. At that time, the only opportunity was to go into general surgery. I did a CT fellowship. After my CT fellowship, I actually got my PhD and did the research in that method. So the the path I took was not the usual path that you see, but you have to realize that the path that you see or that George did such an excellent presentation in isn't always the only path that you can take. So as you can see here, there are multiple pathways to get from undergrad to becoming a board certified cardiac surgeon. The pathway that he actually talked about, and one of the most direct pathways that we see today, is to go from undergrad to medical school to the I-6 program, and then to become a board certified cardiac surgeon. So if you talk about where you're making the decision, I would consider that an early decision process. So yes, you can make that decision early and go through the process quickly. You can also make the decision to go to medical school, then to go into a general surgery fellowship or residency. Some general surgery programs allow you to do 2 years or 3 years of research. You go back into your general surgery program, and then you can go along two pathways that again were described to you earlier, either a 4-3 pathway in which you do 4 years of general surgery, then go directly into your cardiothoracic, you're accepted early into that, or you can do a thoracic fellowship after 5 years of general surgery, and then go and then become a board certified cardiothoracic surgeon. I would say that this is what I would call your mid career decision making. You decide that you're going to medical school, but then decide you want to do general surgery first, which is absolutely acceptable. Perhaps do some research, then do either 4-3 or thoracic surgery fellowship. Another pathway you can take is, for example, if you're doing an undergrad and you're doing some research. Perhaps you had no idea in undergrad or even while you started your research you wanted to go to medical school. But that pathway then takes you into medical school and then again down the general surgery pathway here. I've also seen people do this where they start in undergrad doing their research and then go down the medical school I-6 pathway. I would say that this is a later decision-making process. But again, all three processes get you to become a board certified cardiac surgeon. And then there are the very later ones where you actually have other professions that go into medical school. For example, you have your electrical engineers, perhaps they've been out working, nurses, other medical professionals who then go back to medical school and can either go down, again, the I-6 pathway or the general surgery pathway. So again, when you are talking about when do I have to make the decision, or goodness sakes, I'm doing research now. I didn't make that decision way up here. I'm behind the ball game. I'm never going to make it. Or I'm doing something else. I'm I'm an engineer and I went into medical school. Or I'm in medical school now and I want to take some time out and do research. Just because you're on an alternative trajectory doesn't mean it's the wrong trajectory. And whether you make your decision early, mid, or late, it doesn't mean that you can't become a cardiothoracic surgeon and perhaps have even a little bit more information, a little bit more experience under your belt, depending on which pathway, which timeline that you actually decide to make that decision. And so I know that George did go over this already. The American Board of Thoracic Surgery on its website actually delineates the 4 pathways to certification. Pathway number 3 is the one that we are most used to talking about this day and age. Someone actually called it just a minute ago the de facto. Will it ever be the de facto? And pathway 3 is a successful completion of a 6-year integrated thoracic surgery residency. By completing that, you then would be eligible to take the American Board of Thoracic Surgery's qualifying and then certifying exam. Pathway 1 is actually the other pathway that was talked about earlier. Whether you're doing a 4-3 of general surgery or 5 years of general surgery and then a fellowship, you are then board eligible. The other two pathways they delineate are if you do a 5-year residency in Canada and you're eligible, and then if you complete another American Board of American Board of Surgery residency, for example, a vascular surgery residency, and then would be also eligible after you've completed a fellowship in cardiothoracic surgery. So again, I just want to reiterate that the decision-making process does not have to be one where you make it in grade school or in pre-K. It doesn't have to be made in undergrad where you go directly to medical school. It can be made while you're doing research. It can be made in undergrad and then go through an I6 program. It can be made undergrad and go into medical school and that decision made here. Or you can actually be out working, go to medical school and decide you want to become a cardiothoracic surgeon. It's almost like the idiom, all pathways lead to Rome. All pathways can also lead to cardiothoracic surgery. And the decision doesn't have to be one that is made immediately as soon as you get to undergrad. It can be made at any time. And I know phenomenal cardiothoracic surgeons that have made their decision along each one of these pathways. Do you have any questions? And again, I would like to thank the Thoracic Surgery Medical Association for allowing me to take part in this annual presentation. And if anybody has any questions, I'd be more than happy to answer them.
Thank you so much, as always, Dr. Milewski. Your story in terms of how you were able to find cardiac surgery is so inspiring. I remember you telling me about it very intimately. It was really great to sort of learn about the pathways you took and what different things that you had to encounter to sort of overcome and be resilient through all of it. I've gotten a lot of private messages asking for your contact. So if you're willing and able to share that, that would be great. They'd love to connect with you after this presentation. So the first question that I'm seeing here is that for an IMG aiming to pursue the traditional pathway via general surgery followed by CT fellowship, what differentiates successful applicants from the rest?
Well, I think we've already talked about that earlier. Again, there's not a lot of board exams or, exams that we're utilizing or we get the answers to utilize as a differential anymore. So again, as we talked about, doing some research in the cardiothoracic field, that always helps to differentiate somebody who is actually interested in cardiothoracic surgery versus somebody who is not interested or who has just made the decision, but somebody who's put the time into it and has really thought about it.
Absolutely. And our second and last question, given time, if you're interested in the 4+3 pathways, but do you have to apply for general surgery residencies that have those pathway options, or can you do a GS at one institution and then apply 4+3 at a different institution location if the home institution doesn't offer the 4+3 pathway?
It's my understanding that you can apply to a 4+3. It doesn't have to be in your institution, but I would check with the American Board of Thoracic Surgery first. I'm not certain about that, but it's my understanding that you can. Most of the people that I have known have been in their own institution.
Okay, sounds good. I know, Mark, you have some stats that you want to share with us based on the survey.
Yeah, absolutely. Thank you so much, Dr. Milewski, for your talk. Among the responses that we had, about 2/3 actually have decided that CT surgery is kind of the path they want to take in pre-med and MS1. About like 30% decided maybe in their mid-clinical years, and then the small minority actually decided later on MS4. And so it's, I guess, very refreshing to hear that it doesn't matter when you decide; it just matters, getting on the right path.
Absolutely. Okay. With that, we'll move on to the next presentation to Dr. Carmelau.
Okay, so first job choice, what is the ideal environment? And again, this is your first job choice. And so I'm going to confine my comments to what I think is probably the safest road to a successful career in any environment. And I think that those evolve as your career evolves and as you develop niches and interests, as well as competing things that will decrease your bandwidth a little bit. Next slide. One disclosure, I am a consultant for Edwards. Okay, so this is where I work. As I said, both I guess what you guys are calling an academic environment, which I actually hate that term. So I'm going to sort of reframe that. And then Akron Children's is the largest freestanding children's hospital in Northeast Ohio. Next slide. Okay, so university-based practice is what I would really consider to be akin to what is mostly termed academic practice. Community practice is also, I think, really the wrong term. In congenital, again, there really is no community practices. You either practice at a freestanding children's hospital or you practice at a hospital which is a children's hospital within an adult facility, or very rarely adult congenital surgeons who practice potentially at just an adult hospital. So I don't really think there is such thing as community practice. I think that there probably is those types of environments for general thoracic and adult acquired surgeons. Hybrid, I would say surgeons really who travel between a community hospital to a university-based practice or vice versa. And then I think there's a lot of international and regional networks, which is becoming more and more of a common environment for all types of surgeons. And that is surgeons who really practice at a hub and a spoke type of environment where you could either be at the hub or you could be at a spoke, but you are connected and integrated into a larger practice. And for congenital, that is really the path to certification for many hospitals, which do a certain number of cases that fall below what we consider to be comprehensive centers. Next slide. Okay, congenital surgery, again, is unique, and I apologize. I'm really very sort of in the weeds in my own practice, so I'm going to defer to my other colleagues to maybe speak a little bit about the other specialties. But 80% of practices, or 80% of surgeons who come out of ACGME fellowships in congenital practice at freestanding children's hospitals. And these are really not community hospitals because, by definition, they may not be necessarily located where there is a university, but they have spokes to those university practices. And that is often where many of our adult patients receive their care. Collaborative networks, as I alluded to, are becoming more and more common. And I would say as we go forward again in certification for hospitals, just like ACHA has certified adult congenital practices, pediatric practices will be certified hopefully in 2027 in much the same way. Next slide. All right, so let's get to what you guys are all thinking about, even at sort of this nascent stage of not yet being practicing CT surgeons. But it is really important, especially for congenital, to start what I would say choreographing your career such that you will have all of the options open to you. And that is especially important in pediatric and congenital because there are such limited jobs, and even more limited jobs going forward with all of the fellowships that are expanding. I think there's now potentially close to 18 congenital fellowship spots that rotate from year to year, but there are no more jobs. So there is going to be a funneling toward these types of environments. And it is very critical in order to not have fall prey to attrition in your first job, which is unfortunately exceedingly common in congenital, to choose wisely. I tell all of my residents who are graduating, I just, one of the CHSS, Kirkland Ashburn Fellows, Jim Meza, just texted me and a long sort of, road, just signed his first contract. So I spend a lot of time mentoring residents coming out of their congenital fellowships and their I6 residencies. And I tell virtually all of them, your first job should be in a larger setting, and there should be more surgical faculty for congenital surgeons. My own feeling from anecdotes and, being in this field a long time now, that you don't want to really stake all of your claim with one person. We've all been in relationships. Some of them work, some of them don't. And if everything depends on one person in your career, I think you're taking a big risk, and you are going to depend on that person to give you cases. In congenital, you're going to depend on that person to continue to mentor you and teach you. By the time you exit congenital fellowship, even 2 years, you are not going to be ready for independent practice, especially for complex neonatal surgeries, and you are going to depend on your senior surgeon faculty member to help you along that pathway. So again, my strong advice, ideal environment, pick a university practice, have the ability to work with many different surgeons so that you can develop certain niches. Many large university-based practices have surgeons that are already in niches. Some of them do neonatal surgeries. Some of them are focusing on complex valve repairs. Some of them biventricular repairs. Some of them adult congenital, and finally transplantation. So if you want to have the full depth and breadth, I again think it's very important not to limit your scope of practice by not being at a university hospital setting where you are going to do the full spectrum of pediatric and congenital cases. Next slide. So questions from the group, I will say, I have really seen a lot of these different types of practices throughout my career. I think they all have really wonderful things about them, and they all have some things that, sort of the warts that you might not see right away. But again, first job, I would say university-based practice, have a couple of surgeons, do the full scope, and then you can sort of pivot depending on how you have choreographed your career. Are you going to be an educator? Are you going to be a surgeon scientist? Those things also will clearly dictate and individualize your pathway based on things. Obviously, if you're going to be an NIH-funded surgeon scientist, you're going to need to be at a big university setting. For peds, again, it is a very sort of different landscape. And the most important advice is trust your mentor and stay in close touch with them. They're going to help shepherd you. And if you stumble along the way, you're going to need those people to help pick you back up again and get the ship righted. So have those folks, in line and utilize them. That's what we're there for. Happy to take questions.
Thank you so much, Dr. Carmelau. We really do appreciate the wisdom that you shared through this presentation. Are there any questions from the audience that people have about being able to find your first job? I see, looking back at your own journey, what was the single most pivotal decision or mentor that shaped your career in CT surgery?
Yeah, that's a great question. Just like I think Dr. Maluski sort of crystallized in her mind the minute she, sort of landed on CT surgery, I can really think back to my career, to the person that inspired me. And that was Ross Ungerleider when I was, a general surgery resident. And he was kind of one of these people that made you feel like you could do anything. And, he was an idea guy, and, really just paved the way for me to a larger network of congenital surgeons, and got me my first TSFRE grant looking at fetal sheep surgery, and helped me get the Kirkland Ashburn Fellowship at Sick Children's. So, and I just recently was at his retirement party that his son Graham threw for him at the STS in New Orleans. So, really came full circle just to see all the people that he has helped motivate and shape along the way. But he, larger than life character, and yeah, never forget all the lessons that he taught me.
All right. Thank you so much, Dr. Caramello.
You're welcome.
Absolutely. So we'll move on to the next portion, which will be a quick 5-minute panel. Or do you want to comment on this photo, Dr. Caramello?
Oh, no, I don't. I'm not sure how this snuck in there. This is just me operating with one of my really, really trusty surgical PAs, John Neff.
Awesome. Thank you. All right. Our next basically featured surgeon is Dr. Gerard. He is unable to make it tonight, but I hope to sort of open the floor to Dr. Caramello and Dr. Malewski, talking about how they redefine success over time throughout their careers. If Mark can share some of the data that we got from our survey.
Yes, I can. The question was, your 10 years into practice, what does success look like for you? About 40% of people said leadership with an education focus. Just under 30% said balanced life with protected time. About 20% said high volume surgeon. And then the remaining portion was split between all of the above and surgery and running a lab.
Yeah, I think this is a really important concept. And I think this sort of, highlights what I was talking about, which is choreographing your career. I think success is an individual definition, and everybody has to really introspectively ask themselves what it is that you want to get out of your career. I think few of us going into CT surgery would aspire to work-life balance. Again, I think that is, obviously a laudable goal, but if that's your aspiration in CT surgery, you might want to tuck that away, because it's really about all of the other things in your career that will give you a sense of purpose, and really your true north. And in 10 years, that could be leadership. I think it's probably a bit unrealistic to say 10 years after you graduate, you're going to be in leadership positions. Most of those things happen, I would say, 15 years down the road, and sometimes 20 years down the road, in terms of what types of leadership positions you are talking about. If they are chief or chair jobs, those are going to be, stretch goals. If they are leadership positions in committees or in societies, I think those are aspirational within 10 years. Some societies take a little longer. AATS, for example, you have to be in practice for a certain number of years before you can be inducted as a member. Other societies, not so much. But I would say, think about what you really want to do. Do you want to be the highest volume surgeon and a technically excellent surgeon? Do you want to, again, define yourself as a surgeon scientist or a surgeon educator? Those things are not necessarily mutually exclusive, but if you want it all, then you have to script things. And again, as I would say, choreograph those things. So you can have all of those things. But I think 10 years is probably, in my opinion, a little bit unrealistic. I don't know what you think, Dr. Malewski.
Yes, and I would agree with that. And again, as I'm looking here at the naming of this, redefining success over time, I do agree with Dr. Kamalu, where you have to identify, early what you would like your career to look like. Not necessarily that it's going to go along that path, but you have to start, making some of those decisions early. Obviously, the most important thing to do when you start out whether you're in academics or you're in private practice, is to make sure that you're a good, safe surgeon. And that is defining success in your initial period. Once you've defined yourself as that, then you have to find out in your own mind, what do you think is the most important thing for you to do? Do you want to be an executive? Do you want to be the head of a division, the head of a department? Do you want to be that type of a leader? As Dr. Kamalu said, do you want to be a surgeon scientist? Well, if you want to do that, then you have to identify getting grants, getting money. If you want to be an executive, do you need to go along the lines of taking some leadership courses, whether those in the STS or the AATS? And then in your own mind, you have to think of what is self-satisfying to you as to why would you do this? Why would you go into academic medicine even to begin with? Well, one of the things that I look at, and one of my very good friends delineated, and I know I've told many of you this before, is that your success as you go further and further along your career is really not defined by the number of cases you do, or even, to some extent, the number of publications you publish, but in the number of residents that you've trained over time. Because there's nothing, as I go along toward the end of my career, there's nothing more satisfying than walking down the hall at the STS and recognizing what used to be your resident after resident after resident. George, you were my resident, and they're coming up to you and, just giving you, a hug or hi, how you're doing. And you see each one of your residents standing on the podium. That is defining success as well. So each part of your career, as you move along, is going to change as you move along. And as you succeed in one thing after another, you're going to settle back into that knowledge, or that comfort into your own mind that, yes, I have accomplished this and I've accomplished that. But I look around me at the STS or the AATS and look at all of the medical students, as I see you all here today, residents, attendings, that I've all touched in one way or another and helped maybe not define their career, but at least touch their career. And that will be defining success over time.
What a beautiful note to end on. Thank you so much for being able to share such heartfelt anecdotes and also stories that really put into perspective what it means to sort of really see other people succeed and follow through on their journeys and their careers and dreams. And so with that, I think
I would like to make one more announcement, because I was not sure of the question of whether the 4+3 must be at the same institution. I did look it up on the ACGME website, and it says that applicants must complete all general surgery and thoracic surgery education and training at the same institution. I also reached out to one of my colleagues who did a 4+3, and she confirmed that it must be done at the same institution. So I wanted to make sure that everybody had that piece of information.
perfect. Thank you so much for circling back on that. Oh, go ahead, Dr. Kamala.
No, I just wanted to say thanks to everybody, and thank you, Nina. It's a pleasure getting to know you at the STS, and congratulations to the whole your whole team. Really, just a fantastic job, and thanks for having us all on.
Absolutely. There's still more. There's still a few more things we want to get through. A few announcements. First and foremost, our first international conference for future cardiothoracic surgeons. There's a short video that we want to show just to sort of get people engaged and want to register. So I'll let Kiana play it if the audio is working. I think you might have to go off mute, Kiana.
Across cultures and across time zones, a new generation of surgeons is rising.
A generation driven by curiosity, collaboration, and a shared passion for cardiothoracic surgery.
We're proud to present the first international conference for future cardiothoracic surgeons, the ICFCS 2026.
A truly robust student-led initiative jointly organized by the Association of Fish African Cardiothoracic and Vascular Surgeons, Thoracic Surgery Medical Student Association, Vector Netherlands, and ACTS Student Education.
ICFCS 2026 brings together aspiring cardiothoracic surgeons from across Africa, Europe, and North America.
Our mission is simple but powerful: to make a high-quality cardiothoracic education available, accessible, inclusive, and collaborative.
Team, uniting hearts and hands, shaping the future of cardiothoracic surgery together, this two-day virtual conference is designed for students and early trainees at every stage.
Participants will engage in expert-led webinars covering adult and congenital cardiac surgery, general thoracic surgery, transplantation, structural heart disease, perioperative care, and global training pathways. With live discussions, interactive Q&A sessions, and recordings available for on-demand learning.
ICFCS 2026 also features a virtual basic surgical skills workshop.
From instrument handling to surgical fundamentals and essential cardiothoracic procedures, designed for beginners, intermediates, and advanced learners.
Because no matter where you are, skill building should never be out.
We're also proud to host an international abstract presentation competition,
Showcasing student research, case reports, and academic research.
With awards for Best Abstract, Best Case Report, and an Audience Choice Award.
ICFCS 2026 is more than a conference. It's a global network.
Mentorship platform.
And a shared step towards the future of cardiothoracic surgery.
Whether you're just discovering cardiothoracic surgery
or actively preparing for a career in the field,
this is your space to learn, connect, and grow.
Join us at the first international conference,
Future Cardiothoracic Surgery.
ICFCS 2026.
Uniting hearts,
Uniting hands.
shaping the future together.
We are so very proud to be working with our peers across the world in terms of being able to put this conference together. It was an idea that was ignited in August of last year, and just being able to see how well we were able to develop our website and just seeing the momentum with it. We just really look forward to being able to see each and every one of you guys April 11th through 12th and sort of go through the amazing lineup that we have from world-renowned surgeons from across the world about their experiences and talk about their specialties and just getting more people engaged in everything. So feel free to scan the QR code on the flyer. And Dr. Malusky, I'll let you also share your thoughts.
That was absolutely wonderful. I think bringing together all of these things or all of these international ideas, international thought processes, everything is just phenomenal because the world is getting smaller, and we have to make sure that we engage everyone. And I think that the work that you have done is absolutely phenomenal. Absolutely phenomenal.
Thank you. It's the whole team. It's the whole team. So glad for everyone that got involved, the late nights, the late calls. So it's really great just to see everything come together. And we look forward to seeing everyone very soon as the conference is coming up in less than 6 weeks. So feel free to register. The registration link is right there. There's an early bird deadline as well as a regular deadline. And we look forward to seeing you. With that, we'll talk a little bit more about our STS partnership. We are so glad to be in partnership with the STS. Again, we've been working with them with our mentorship program, and so we're trying to expand opportunities for medical students interested in CT surgery. Through this partnership, we're able to give an award to the person who won their lottery this evening. So if you go on to the next slide, I'll let Mark take it away.
I want to extend a congratulations to Desmond Perry. I hope I'm pronouncing that correctly for winning the medical student membership for the STS. So expect an email from us very shortly with the next steps.
Congratulations, Desmond. We're so glad to have you on board, and we look forward to hearing from us very soon about next steps for being able to get your free membership, a free $25 basically. So excited to see you got engaged with STS and get and basically in touch with all the different experts and advance your career through that year of having a free membership to the organization. So with that, we'll move on to the next segment. We are a little 5 minutes behind, but we should be good. Again, we have featured residents from TSMA, and oh, go ahead, Dr. Malusky.
One more thing, I'm not trying to beat a dead horse here, but I just got another text from my colleague who is a 4+3, and she said to anyone who's interested in that to make sure each year they check the ACGME website because that's where the information is located. It could change, and to make sure to continuously check the ACGME website. I apologize, but I wanted to make sure everyone had the most updated information I had.
Absolutely. Thank you so much for your due diligence. I really appreciate it. Okay, so with that, we'll open up our CT surgery resident breakout session rooms. Kiana, feel free to open the rooms. We have amazing residents from across the nation who are willing to talk about their experiences in CT surgery spanning all different years of residency. So feel free to join a room based on your availability and what you're interested in learning more about. And we can reconvene. Actually, I'll let you guys have your conversations. And then when you guys are ready to hop off the call, feel free to. But I think this is going to be great.